Hi, everybody, and thanks for joining me. Sorry, I'm flipping these times a little bit between 9 a.m. and 11 a.m. on Sunday, just trying out different times, see what works best with my schedule, your schedule, etc. So, we're going to be talking today about an online quiz I put together to try to help patients determine how far they may want to go down this rabbit hole of a CCI diagnosis, right? And what I mean by that is that I often see patients who they're pursuing multiple different pathways for diagnosis. They're pursuing, do I have craniocervical instability causing my symptoms? They're pursuing, do I have Eagle syndrome causing my symptoms? They're pursuing, do I have a dural leak causing my symptoms? And sometimes many more. So it's hard for patients to go online and find credible resources one direction or the other. They talk to one doctor, they get this opinion, and they start heading down that pathway. They talk to another doctor, and they start heading down that pathway. So I thought I would put together a quick online quiz that patients could access and my staff could use, number one, in trying to determine whether or not they probably have symptomatic CCI, and also that patients could use to see, is this worth my time? Now, no online quiz is going to be 100% accurate. It just merely represents what I see on a day-to-day basis as I evaluate patients. So that's how I put it together. But I'd like to go through that today because I think it's an important topic, and that is helping patients decide, do I have symptomatic craniocervical instability? Because again, this is a pathway that patients may be pursuing when there are other pathways as well they may want to pursue. Do I have a CSF leak? Do I have Eagle syndrome, et cetera, et cetera. So we'll do that, and I'll go through that online quiz briefly, and then we'll go through questions. I can see already I've got a bunch of questions here. So let me go ahead and pull up that quiz. Okay, so this is the quiz, and again, it's being used by my staff to help them determine which patients really need the most attention in trying to figure out, do they have a craniocervical instability issue causing their symptoms? We want patients to take it as well. So I'll put the link to this online quiz in the comments here so that you guys have it. So that should get into the comments there. Yeah, looks like it did. So anyway, let's go through this a little bit because I think it's important for patients to understand, because again, just because someone said your imaging looks like X or imaging looks like Y doesn't mean you have symptomatic craniocervical instability. So these are the things I would go through in trying to make that diagnosis. So number one, do you have any history of significant head or neck trauma that caused these symptoms? That means that your symptoms began within a few weeks of that trauma. Let's click yes there. Number two, do you have hypermobility or EDS? That's another possible cause. I'm going to click no there for this time. Now, note what's not here. What's not here is mold illness. What's not here is Lyme disease. Right now, we don't have any credible information I can find that would link either mold illness or Lyme disease to CCI. So whether you have that and are pursuing that, for me, is going to be very separate with regard to making this decision of craniocervical instability. So again, it's trauma or hypermobility. Now, sometimes the trauma is more distant, so there is the possibility of the trauma being in your past, and it was a sizable trauma. It had symptoms with it. Eventually, the symptoms went away. And then some smaller trauma brings it out, and I would call that the straw breaking the camel's back, right? Someone had stretch out ligaments from a long time ago. Let's say 5 years ago, they were in a car crash. Their neck hurt for a couple of weeks. Maybe it still hurts today off and on, but their main symptoms didn't begin until 2 weeks ago when they got up, tried to get out of a car, and they hit their head on the roof of the car. So that's more the straw breaking the camel's back. This quiz doesn't account for that because that's something I've got to get through history. And then we go through all of these different symptoms here. So I'm going to go through the typical ones: headaches or pain in the upper neck at the base of the head or head pressure. I'll check dizziness and balance that occurs when you look at something or are active. This differs from dizziness getting up from a chair when standing. And we'll click brain fog here. And then we'll go to the next one. When I wear a cervical collar, some or all of my symptoms get better. I'll say yes. And down here, I saw an AO or nuclear chiropractor, and that made my symptoms temporarily better. So we press submit here, and it just says likely to be symptomatic CCI. Now, this is not going to render a diagnosis. It's merely going to give you as a patient some idea of how I'm going to view all of this information. So let's take another test now. Let's go back here and say there was no trauma. There is no EDS. My symptoms, I don't have any neck pain, dizziness, headaches, etc. I've got some tinnitus, and I've got some nausea, and I've got some rapid heart rate. Wearing a cervical collar doesn't change anything. Seeing a NUCA chiropractor or AO chiropractor didn't change anything. Now I take the test, unlikely to be symptomatic CCI. So you see there the differences here, right? There was no trauma. The person's not hypermobile. And I don't have the main symptoms usually associated with CCI: headaches, dizziness, and then something else like brain fog, tachycardia, etc. So obviously we can weave through middle of the road scenarios, but you can see here again, when I wear a cervical collar, nothing changes. I go ahead and I see an AO or NUCA chiropractor, that doesn't do anything. So I would encourage you, if you're a new patient who's trying to see, should I pursue this CCI road or should I pursue some other road, right? Someone else is telling me I may have a CSF leak or I may have Eagle syndrome. This is just to try to help you determine which path would make the most sense for you. So it's available. My staff will be using it to try to help them find which patients are more likely to be helped by what we do. And in addition to that, I want patients to jump on here and use this. So I've put the URL that goes here into the comments. So let's go to questions now, because again, this is a show, or this presentation, we learn by answering, or we learn by asking and answering questions. HRS. Doctors, standard practice across all regenerative practices use anticoagulant in the syringe used for bone marrow aspiration. Can you elaborate more on this and the consequences of not doing so? It is standard practice. Without the coagulant, you end up getting clots in the bone marrow aspirate, and you lose stem cells in those clots. So once you get a clot, you can't really unclot it easily. And so that means that we do use an anticoagulant to keep things from clotting. HRS are intra-articular injections in the knee performed by regenerative physicians, supposed to be blind or ultrasound guided. They should all be at a minimum ultrasound guided. And if they're not, that's something you would want to let me know about. HRS, during a knee procedure like the PICL, is a nerve block used into the nerve or not? If yes, are the nerves injected using ultrasound or blindly? Usually for something like a PICL procedure where a needle is being used to place cells or PRP directly into an injured ACL, the focus is not using a nerve block. You could block the knee, but the problem there is there's really no way to block the knee easily without also losing function of the muscles. And so I wouldn't recommend using a nerve block in that case. For our clinic, we would use some local numbing using ropivacaine, which has the least likely effect on using cells. And we would also use some IV sedation if the patient required it. Philip, what's the typical duration of PICL procedure itself? And could you please post your assistant's contact details? Carla again. My assistant is Ryder now. And I'm pretty sure this is right, but I didn't really check this because it comes up automatically when I send Ryder an email, but it's Ryder. I just put Ryder's email in the comments there, so everyone's got that. As far as the typical duration of a PICL procedure, typical duration, it's going to start with an eval in the office. Usually that's 40 minutes or so. Actually, it starts before that. 40 minutes of telemedicine, 40 minutes of hands-on in the office. Then, assuming that person's still a candidate, then there's a bone marrow aspiration. The bone marrow aspiration takes 30 to 40 minutes, somewhere in there. And then the PICL procedure itself, if it's myself, since I've done by far the most of them in clinic, I tend to be able to do them with the most facility. And for me, it's usually clocking in at around an hour. Sometimes we'll go to an hour and a half, depending on all the different things that have to be injected. Some of the other doctors, I think it's taking longer for them because they don't do as many as I do on a daily basis. So they're taking, let's say, add a third onto what I just told you. AT, thoughts on bringing my dental roll and using it in office for traction immediately prior to the PICL procedure. Could this help? Probably not going to make a big difference using it just prior. HRS, can scar tissue and Hoffa's fat pad in the knee due to previous surgery be injected with stem cells in an attempt to stimulate natural growth of the fat pad? Unlikely. If you were going to try to do something like that, you would probably want to harvest fat from the healthy Hoffa's fat pad and transplant it into the unhealthy one. But that's a big if, because you first would have to prove and be fairly convinced that the person had some pain or disability being caused by that scarring in the Hoffa's fat pad. And that's not so easy to do. AT, for fascial injury with rib cage, is fascia hit as well as posteriorly in general? Would postural muscles be injected at the same time? Yes, fascia around the rib cage would be injected. As far as postural muscles, not quite sure what you're referring to there. HRS, doctor, I've seen a cadaver with an Achilles tendon strain near where it attaches to the thigh muscle. Fascia of the tendon at that spot have become one and scar down. Treatment for such adhesions. Achilles tendon doesn't attach to the thigh muscle. Maybe you're talking about to the gastrocsoleus complex there. And if it were an injury between the muscle and tendon, or the musculotendineous junction, then that's the area that we would hit specifically. And that's usually something like PRP, depending on how severe the problem is. Jessica, does overhang C1, C2, and DMX only indicate alar ligament damage? Not necessarily. The biggest controlling ligament there would be alar ligament, but like most things in the body, there is quite a bit of other things that control those sorts of motion. So for example, the accessory ligament would probably also be involved, and then others as well. AT, after PICL, is it recommended fish oil and stem cell formula be restarted immediately? Some strong opinion on waiting a month after PICL resumes, supplements on Facebook group. You can restart both immediately, not a problem to restart both of those after the procedure. The reason why we have the patient off fish oil in particular is because it's a blood thinner or acts as a blood thinner, and we find that we get excessive bleeding at the back of the throat when patients stay on fish oil. Alexis, if you have been told you're a candidate for PICL but do not wish to do it, can you still see results from posterior PRP? Yeah, Alexis, a lot of that just depends on the type of instability you have. So if you have, for instance, a type 3A instability where you've got movement of C2 on C3 inflection, posterior injections can be very, very helpful. Posterior injections can also help calm down some of the pain coming from the upper neck joints or nerves. But if the instability is still there, all of that's eventually going to come back. Alexis, do you recommend cervical curve correction before or after prolo PRP? Should someone continue with it if it exacerbates symptoms? Yes, remember, I think, Alexis, and you've probably heard me talk about this, if you are in a situation where improving your curve, let's say a simple way to do that is to roll up a small hand towel and place it behind your neck, lie face up on a firm surface, and see if pushing in that direction anterior or increasing the curve artificially is something you can tolerate. And then you would say, okay, I can tolerate that. I'm going to try some curve correction and see if you can tolerate that. But only if you can tolerate it, right? If it's exacerbating your symptoms, then we don't want you doing curve correction. AT, had a Rolfing session recently and after have been feeling under the weather. Hopeful this turns around fast. How important is it not be dealing with flu-like symptoms prior to PICL? Not quite sure what's being discussed there, meaning did you get a flare-up from a Rolfing session, or do you have a respiratory virus like the flu? Maybe give me some more information on that one. Philip, I'm from Germany and can't get the DMX scan done here. Where and when should the DMX scan be done? And will your clinic schedule an appointment, or how do you handle it in time for the PICL procedure? Yeah, Philip, pretty typical that happens in our European patients. So what happens is they'll come in the day before, they'll meet with Dr. Katz at Dr. Katz's office, they'll get the DMX done. Once the DMX is done, then you'll bring it in the next day and we'll look at it and make some decisions off the DMX. So that's fairly common for my office. Sherry, who does the scheduling, should have no problem in getting all of that scheduled and helping you with that schedule. It's pretty typical. Franco, several papers say that the transverse alar and capsular ligaments, C01, are the main CCJ stabilizers. Why do you then inject C0 in joint instead of the joint capsules of C0, C1? Yeah, Franco, we inject the joint intra-articular, but we also inject the facet capsules as well. Just realize when you hear providers say they're injecting the capsular ligaments, it really means, in my opinion, that they don't have the skill set to inject the joint. Now, why would you want to inject the joint intra-articular? You would want to inject the joint intra-articular because if you've got instability at the joint, there's some damage occurring within the joint, meaning that we all know that we have finger joints, right? And those finger joints are made up of bone, cartilage, joint, cartilage, bone. And then there's a capsule around those finger joints. Now, if the capsule are unstable, it'd be a good idea to inject the capsule. But if the capsule have been unstable for a while, it means that you're getting early arthritis within the joint and you have to inject inside the joint. So this is kind of a discussion back and forth that really got started by providers who had never been taught and didn't have the skill set or equipment necessary to inject inside a joint. So once you have the skill set to inject inside a joint, you want to inject inside the joint because that's the way to help the patient maximally. You can also inject the capsular ligaments. That's a chip shot if you know how to get inside the joint. HRS, Dr. Can severe left AIC pattern, postural imbalance, be corrected using orthobiologics if aggressive physical therapy fails? It depends on whether or not the problem is being caused by the upper cervical spine. So for example, if we're looking at balance or proprioceptive related issues, those can be caused by inner ear problems. They can be caused by visual issues. Obviously, they can be caused by brain issues. They can be caused by upper neck issues. Now, if all three of those things, the first three, are ruled out, it's not the inner ear, it's not the eyes, it's not the brain, and it looks like on exam it is the upper neck, then sure, you can treat the upper neck and get rid of those proprioceptive balance issues pretty easily, usually. Jessica, would you know if your alar ligament was completely torn versus a tear? The DMX show very bad overhangs with a complete tear. Yeah, Jessica, we've looked at lots and lots and lots of these at this point, meaning DMXs, MRIs, DMXs, MRIs, DMXs, MRIs. And I can count on one hand, meaning of thousands I've looked at, where there's a complete retracted tear in an alar ligament. These are very, very strong ligaments. So what you tend to see is not complete retracted tears. 99.99% of the time, what you see is that the ligament is not able to hold like it should. So there's some micro tearing within the ligament, but it's not torn in half and snapped back like a rubber band. Regenic, submitted advance by John. Can I get a PICL at the same time as doing stem cells in my bulge at 5.6 and 6.7? You could, John. That would be a discussion for you and the doctor as to whether or not, number one, you could tolerate something like that. And number two, whether or not that's the best thing to treat what's going on at 5.6 and 6.7. It isn't always injecting bone marrow concentrate, in this case, into those discs. Astra, love this. Where can I find the online quiz? Astra, I put that down in the comments, so you should see it in your comments. And then there it is, right there. It's in the comments. So it's in the comments. Looks like it wants to all three places: the Centeno Schultz Facebook page, the my personal YouTube channel, and to the Regenix Facebook page. Brian, could you go more in depth on the ePICL? Is it a higher cost? What exactly you're doing differently than the previous PICL? Your video explainer didn't say much. Yeah, so it's not higher cost, the same exact cost. The difference is that after me personally doing, I don't know, close to 1,000 procedures, I was able to develop some new techniques in order to better access the tight band lateral portion of the alar ligament. So it's just getting more of the bone marrow concentrate in more of the ligament than we were able to routinely previously do. Now, I have not put specifically how this is done online because I've already had at least one doctor show up at my office and kind of try to trick us into teaching her how to do the regular PICL, meaning that she was actually there. She claimed to observe Regenix procedures, wanted to become part of the network. Turns out she ended up only observing PICL procedures and then trying to go over to Europe and do PICL procedures. She was told after watching two that she had no ability to do PICL procedures. This was not a watch one, do one type scenario, meaning this was far more complex than that, but she did anyway. So as a result, I don't talk too much anymore about how these things are being done. Once I made those discoveries, I transferred that information to Dr. Schultz and Dr. Pitts, who are the only two other people on earth who are, in my mind, capable of doing this procedure. And we're going to keep it that way for a while, trying to avoid what I consider could happen with this procedure is some really, really bad result out there, ending everyone's ability to get a PICL procedure. Submitted advanced by John Gardner. Are there any exercises that can help strengthen the alar, or is PICL the only way to full recovery? I wouldn't say exercises would be the answer. We have certainly seen, and I think Dr. Katz has done some good work in looking at getting the curve back in select patients and then offloading that area, activating some of the upper neck muscles, and providing better stability for that area. So there are certainly other things to pursue in trying to recover naturally. And I always tell patients to definitely pursue all of that and feel comfortable that that's not going to work before trying something like a PICL or ePICL procedure. Zach, how do stem cells, BMC, PRP, and prolotherapy compare for treating loose ligaments? If the ligament is loose, would prolotherapy best to tighten it, or can other methods both tighten it and heal it? Yeah, Zach, the example I usually give is SI joint instability in women. Usually that's 6 to 8 prolotherapy visits. It's about half as many PRP injections. So now we're at 2 to 3. And if we use bone marrow concentrate, it's 1 to 2. So that gives you some sense of how they stack up and their ability to help ligaments tighten and heal based on my clinical experience. HRS, can injury to the secondary patellar stabilizers, such as the MP, I think you probably mean FL. And so basically, the patellar retinaculum be diagnosed and treated. And if so, I am not referring to the MPFL. Yeah, so all of what you're talking about is part of the patellar retinaculum. We as doctors love to place specific titles or specific names on things, but this is all part of one structure around the patella that has some thickening in the bands, if you will, but it's all a single structure. So, and the answer is, can you injure the patellar retinaculum? And that can cause patellar instability. Yes, we see it all the time. Can that be treated usually with orthobiologics? Yes, it can. Franco, when do you expect to publish results from randomized control trial of the PICL procedure? Franco, we have not been able to recruit the randomized controlled trial. We'll be publishing our third analysis of the retrospective data coming up here. And that'll be part of a larger publication where I also introduced the grading system that I created and just an overall review on this type of craniocervical instability. When will that be done? My sense is we'll probably submit that in the fall, including that third analysis. But the randomized controlled trial, we could not get people to go into a sham treatment group. And that's not, I mean, that's kind of to be expected, right? It's not just someone with knee arthritis who's limping around. It's someone who's got a very severe disabling condition. And the idea of having to go through 2 fake procedures as part of the randomized controlled trial proved just too much for patients. They weren't interested in doing it. Regenetics, submitted advanced by John. How does CCI affect heart rate variability? I don't think anyone knows the answer to that, John. I think the overall conceptual understanding would be that in some patients, heart rate variability is increased as a result of irritation of the vagus nerve, but I don't think anyone has done any research that I know of on that particular topic. Tasha, this is exposed Chiari for me. Can these injections help all of this? Not sure what that means, but I think what you're getting at there, Tasha, and you can tell me if I'm wrong or right, is Chiari malformation is when the back of the brain hangs too low. And the vast majority of patients that we see have a Chiari 0, or what's also called CTE, cerebellar tonsillar ectopia. Now, the problem is there's a lot of people walking around out there with a Chiari 0 or CTE that have no symptoms whatsoever. So Chiari by itself is relatively meaningless. And I want to make sure you heard that. Chiari by itself is relatively meaningless. What seems to cause some symptoms, though, is when you get craniocervical instability in combination with Chiari 0. There's at least one paper that talks about there being a connection between those two, and that taking a normal problem, Chiari 0, and making it symptomatic. So very important to understand that distinction in talking about all of that. HRS, can the ALL be injected using orthobiologics since it is commonly torn with the ACL? It's being treated in Colorado, and what is the procedure? Yes, we'll typically inject the ALL, anterior lateral ligament of the knee, when we are injecting the ACL. It would just be part of a PERC ACL procedure. Athena, is it useful to work on curve restoration prior to ligament resolution? Many different opinions on this being not useful. This probably just was online devices for those intolerant to Denerol. Yeah, Athena, I think the controversy comes from some of our patients can't tolerate this at all until things stabilize in the upper cervical spine. I think anything you can do that you can tolerate that'll increase the curve, like using a rolled up towel and lying face up on a firm surface, as long as it feels good, it feels right, would be fine. And then as you were able to tolerate more as the instability got stabilized, you would hopefully then graduate to Denerol and other things. Jessica, I've had x-rays, CT scans, MRIs, visits with neurosurgeons, neurologists, and none of them are able to see anything obvious in my scans to explain how horrible I feel. Why is CCI so hard to detect? I don't think it's hard to detect. It's just a highly, highly specialized area. So I think, one of the things I often tell patients is that I don't know how many neurosurgeons and orthopedic spine surgeons are out there. I'm going to guess, let's say in the United States alone, probably 10,000. And despite that, there's really only 4 surgeons in the United States that do 80% of this type of CCI surgery, meaning surgery not for when someone's head's going to fall off after a car crash scene in the ER, but more for symptomatic craniocervical instability that's not due to huge trauma where someone's head's going to fall off, and you're talking about an elective surgery. So 80% of that is done by 4 out of, let's say, 10,000 spine surgeons. If you see one of those 4, they'll have no problem helping you diagnose craniocervical instability. If you don't see one of those 4, it's going to be very hard to diagnose. Same thing with a CSF leak, right? There really aren't that many doctors that see a lot of CSF leak patients. So you're not really going, your likelihood of finding one who's an expert in that area is really, really small. Or same thing with many rarer diagnoses. If you don't see the right specialist, you don't get the diagnosis. Zigzag, last week you mentioned custom injections. What are some examples of custom cervical injections you perform? In instances, would you perform them? Yeah, I think what I was referring to there, and correct me if I'm wrong, was the conversation was around is the PICL a standard thing? And the answer is there are certainly components that are standard, right? The PICL procedure itself, injecting alar, transverse, AAOM, and a whole host of other internal ligaments. Having said that, patients come in having usually been injured someplace, and that injury may extend beyond just craniocervical instability. They may have also injured upper neck facets, so those would get injected if they were injured. They may have irritated occipital nerves. Those would get injected if they were problematic. Many patients also come in with both upper and lower cervical problems, so both of those get treated. Some of our patients have thoracic spine problems, which are quite disabling as well, so those get treated as well. So as you can see, since every patient's going to be different, there's going to be some commonality between PICL procedures, obviously, but there's going to be as many differences as there would be commonalities. Sonia, hi, Dr. Centeno, have you found any evidence in your research that autoimmune dysfunction impacts the effectiveness of PICL? No, Sonia, I would say probably a third of our patients have some sort of autoimmune diagnosis, and we don't really see that it makes a difference. Usually for us, that's linked to patients with HEDS, and the only difference in HEDS, as I've talked about, and as we've looked at this data, is that they end up in the same place, but HEDS patients tend to take more treatments. Regenix, submitted advanced by Sherry Scott. I was recently told I may have a CSF leak, but no suggestions or referrals made to treat it. How is that treated? Yeah, Sherry, so this is an important question. If I were to do a questionnaire, for example, for a CSF leak, there's a couple things I would put in there as a doctor, right? I would say patients with CSF leaks are worse when they're sitting up or standing up. They get a severe ice cream type headache, but they're dramatically better when they lay down, and moving their head, their neck doesn't impact anything at all for those patients. So if you think that's you, then you got to get at where is the CSF leak, and that's often hard to find. Specialized MRI, you can kind of see some things, but frankly, I think there's a high false positive rate there, meaning there's a lot of times where someone says, I think there's a leak right here, and it turns out surgically they go in and there isn't a leak there. You can use things like radionucleotide cysternography. There was a Japanese study that did a good job of that. But I can tell you from trying to replicate that here locally, very hard to find these leaks because they're very, very slow leaks. Really, the best you can do is to do blood patches or serial blood patches. And that is, if you think it's lumbosacral, you patch the entire whole lumbosacral spine. Now, that's not easy to do. Patching the whole lumbosacral spine takes about 7 or 8 different injections. If you go to the local university, you're not going to get 7 or 8 different injections because they're not set up from an insurance standpoint to do 7 or 8 different injections. They might do 1 or 2, which means they're doing not a great job at covering the whole lumbosacral spine and ruling it out. They're doing the quickest thing they can possibly do and the least possible to rule that out. So not easy to do, but usually it's serial blood patching. Do Regenix offices in Dallas work with CCI? Absolutely not. There's only one Regenix office in the United States or worldwide that works with CCI, and that's Centeno Schultz in Colorado. That's it. Amain, what does excessive seating? Oh, maybe it's sweating? Excessive sweating? Hopefully it's sweating. They may have misspelled something. Oh, thank you. You found an error there, so I'll have them fix that. That's supposed to say sweating. So thank you, Amain, for finding that. Let me actually do something so I remember that. Okay. This is Ryder's email address for my clinic. Anastasia is, if a complex patient has severe POTS and CCI and is working towards treating infections and other before stem cell, what is good protocol for make use of AO or osteo or upper cervical chiro, etc.? So again, I think it's, if you think you have craniocervical instability, it's always a good idea to see an upper cervical specific chiropractor, AO, NUCA, etc., and see what your response is, to see if you get temporary relief. In the same way, it's always a good idea to try a cervical collar to see what your response is and see if you get temporary relief when wearing the collar. As far as POTS and infections and all the rest of that, I don't think that makes a darn bit of difference either way. Jessica, is getting C0, C1 injections from genetics outside of Colorado risky or safe? I do not recommend anybody get C0, C1 injections outside of Colorado. I think I've been saying that now for many, many, many years. And the reason is that there's no one outside of our Colorado site that does enough of these to be in that safe category. And what I mean by that is this is a procedure that if you get it wrong, the needle goes into the brainstem, or if you get it wrong, you inject into the vertebral artery. Hence, and it's a procedure that's very, very hard to interpret the fluoroscopy image, meaning that 999 out of 1,000 experienced interventional spine physicians, if I put up an image that we use to inject 01, is going to have, they're all going to have a hard time figuring out where things are. So you have to do a lot of them. In addition, you have to do a lot of them to interpret what the contrast conformation part means, whether or not you need to use digital subtraction angiography to make sure that you're not injecting into the vertebral artery. How many is that? I think you need to do 10 to 20 of these a month, minimum 10. That's 100 plus injections like this a year for you to have enough experience where you go into that very likely to be safe category. And that type of volume just isn't done out there outside of our Colorado clinic. Alexis, do you inject tendons and muscles as well as when doing posterior PRP? Yes, we inject tendons, muscles. Again, each one of these treatment plans is going to be specific to that person. So if there are tendons and muscles that need to be injected, those will get injected. Kimmy, how much does stress anxiety affect PICL healing? Very stressful life events right after my first PICL, and I'm concerned I've ruined my chance at healing with this one. Kimmy, it shouldn't really have much impact at all. I mean, I'll give you an example, right? If you have a cut while you're in a stressful life event, that cut doesn't heal any differently. Or if you were to break a bone and have a stressful life event, the timing of that bone healing isn't affected by that stressful life event. It would be the same thing here. Jessica, is your opinion, in your opinion, is Dr. Joel Frank a trusted source? I've heard mixed things. Jessica, I think Dr. Joel Frank is one of those 4 surgeons I talked about that do a lot of craniocervical instability surgery. His focus is usually C1, C2 screw fixation. I think that's his claim to fame. So I think when it comes to competence in doing that procedure, he certainly has the volume to be competent in that procedure. Now, like any doctor, right, I've got my referral sources, meaning, I've looked at the 5 surgeons that do most of this stuff in the world. I've made my own choices based on observing what they do and how they do it, which ones I tend to trust the most, because usually they're the most conservative, meaning that there are 2 surgeons on that list who are really pretty conservative, right? They're not going to operate on someone unless they really think they can help them. And I think there are 3 surgeons on that list who tend to be more surgically aggressive and are more likely than not to operate. And from my personal opinion, I would tend to focus on the 2 that are the most conservative. Kimmy, what can be done about central sensitization? Yeah, Kimmy, as I think you've probably heard me say here many times, I often say to patients in the office, central sensitization is a big problem. It means that the central nervous system in certain chronic pain patients has become way too efficient in carrying pain signals. And those patients are always harder to treat. Now, there are medications that can damp it down a little bit while we treat the person. Lyrica tends to work pretty well for that, or pregabalin. But ultimately, what you end up doing with a centrally sensitized patient is you get into the less is more category. So that means you do just a little bit, see how they respond, do a little bit more, see how they respond, do a little bit more, see how they respond. It just takes longer to treat those patients. And hopefully, as you do a little bit more and a little bit more and a little bit more, the central sensitization component calms down. Sure, Jessica, happy to help. Isn't traction dangerous? I almost died from traction, vomiting, and no visual for 2 days. I understand this is an indicator for CCI. I think it could be an indicator for CCI. Traction by itself is usually not dangerous. It's done all the time. They sell over-the-door traction units online. Now, for CCI patients, it can certainly, with the instability, place certain structures at more risk of injury because of that instability. And obviously, it sounds like you need to get to a diagnosis of why you would have vomiting and no visual for 2 days. That could be craniocervical instability, that could be related to vertebral artery compression, that could be related to a host of other problems or things that need to get worked up and understood, because I think that's an atypical response to traction. And while it could mean CCI, it could mean other things. HRS, so sorry for the typos, referring to the calf muscle. Yeah. Kimmy, what is it about CCI AI that causes derealization, depersonalization? Is linked to brainstem compression or something else? Yeah, Kimmy, I don't know that anyone knows the answer to that. Depersonalization is, excuse me, guys. Even the doctor has to sneeze sometimes. Yeah, I think I hear depersonalization not that often, maybe from 5% of our CCI patients. So I don't think it's the most common symptom at all. What would cause it? Brain fog may be related to it. Problems with eye movement may be related to it as well, meaning that we know that eye movements are linked to memory and memory encoding. So it's possible that it has something to do with that. But I don't have an easy answer for that one. Anastasia, where vascular compression syndrome is an issue and PICL approved for a patient, do you require a patient to see an upper cervical chiropractor prior to the procedure? No, Anastasia, that falls into one of 2 categories. The first category is that someone already has an upper cervical chiropractor, they get great relief, and we want them to continue to play through. The other category is that it's always helpful from a diagnostic standpoint if we can confirm that that kind of treatment will make the person better. Just like it's always helpful from a diagnostic standpoint, using a cervical collar makes that person better. But there isn't a requirement that someone do that prior to the procedure. Anastasia, do Lyme patients qualify as low or no risk? How do you determine categories which to put patients at risk, not good candidates for stem cell? Yeah, I'm Lyme agnostic, meaning that if you have some sort of Lyme spirochete, you have that regardless of what I'm doing. And it doesn't seem to make a difference at all in the outcome of the procedure, nor would it make sense that it would make a difference in the outcome of the procedure, because it's an autologous procedure, meaning you're taking bone marrow concentrate from one area, moving it to another. So I'm agnostic on the whole Lyme thing. I don't get involved in the middle of it at all, because it doesn't seem to really impact what we do at all. HRS, how are MPFL strains treated? What is reasonable to try first if it's only possible to have one clinic visit, PRP or bone marrow concentrate? So for a grade 2, if someone was tied to only a single visit, it would be either, depending on the severity, meaning the actual laxity, because remember, grades are determined by MRI, not by function testing. So if it was more mildly functionally problematic, then PRP. If it was more so, and there was only, you had to confine me to a single visit, I would say bone marrow concentrate. Kimmy, where's the general dizziness most likely to come from with CCI, AAI? I frequently have the feeling of walking on marshmallows, wondering if that Siemens 2 issue may be further down. Yeah, Kimmy, so that's described in the book, and the book is on the CentenaSchultz.com website. I think it's also on the Regenexx website as well. But basically, those are all upper cervical proprioceptive issues that generally come from C2-3 or C1-2. So that's simply bad position sense information coming into the brain that is mismatching other balance information, like balance information that would come in from the inner ear or the eyes. AT, responsible last question, probably a flare-up from Rolfing, but feels like dealing with some flu symptoms, sore throat, fatigue. Yeah, I don't know how to answer that one. If there's a mild flu, it's not a problem, but I don't think the two are related. Meaning I don't think the musculoskeletal system causes flu-like symptoms. Tanya, 20-year cranial CSF leak issues and CCI, 2-time PICL with Dr. Merkel. Part of my knowledge of the cranial CSF issues almost 10 years ago and seizures having started prior to my 4 parts. Getting PICL, suspecting oxygen perfusion may be a component. Have you heard of any cerebral oxygen level testing with monitoring cerebral oximetry and near infrared or similar devices to get a clearer picture? I believe due to continued seizures, the ALR transverse upper cervical needs attention, which I've discussed with Dr. Merkel. Tanya, to my knowledge, Dr. Merkel doesn't do PICLs, so you probably got something else done. And I think probably best to continue those conversations with him, because it certainly sounds like a complex issue in history. Vicky, Dr. C got both knees done in Cayman in June of 24. I've had right knee trouble and had MRIs done 8/15. They should be online at SimonMed now. Yeah, Vicky, probably best to just send me an email directly on that, and I can take a look at those on Monday. Just to remind you, I'll put the email that goes to my desk in here, and send me an email, because that's a better way, I think, to discuss confidential health issues. 5th part, I score high in the CCI test and still leaking post-patch, believed to be due to arterial compression. Red PRP has helped significantly recently with Dr. Merkel. Gotcha. Rich, I read in the Facebook group that your clinic was doing some studies in peptides and how they would interact with stem cells. Wondering if you have any results to share on that. Yeah, Rich, we were looking at that about 2 years ago, and we couldn't get a reliable source of a peptide assay. So what I mean by that is that the first part of that study was going to be determining whether or not the peptides you can buy online are actually real. There are actual confirmed amounts of peptides. So for example, BPC157. Well, it turns out there is no BPC157 assay. Then the other problem we had was getting enough confirmed sterile BPC157 to be able to put it into culture. And we failed on both of those, so we decided not to do the in vitro studies on it. Brian, EPSL cost, mine was $2K more. Yeah, Brian, you may have seen the difference maybe in pricing between getting something a long time ago and today. That could be, but the ePICL doesn't have any different cost than the regular PICL did. Athena, is it feasible to fee-for-service sessions with Dr. Katz for severe CCI patients unable to travel? Yeah, so Athena, that's something you'd have to talk to Evan Katz about. I just don't know. Amin, is there any possibility for you to teach someone in Europe for the PICL in the near future? Yeah, Amin, no time soon. We are still learning things, as you can see with the ePICL variant. So we're going to have to stop learning new stuff, number one. And number two is it's going to take an immense commitment on the part of that doctor. So that doctor is going to have to spend months here in Colorado, not just a day. They're going to need a hypersterile processing for PRP and bone marrow. They're going to need to have 2 C-arms in the room, which is almost unheard of for an interventional spine physician. They're going to need to have endoscopy, specialized 3D printed mouthpieces, etc. So I just don't see that it's practical at this point, nor would it make any sense until we get all the parts and pieces dialed in. Athena, peptide use is extensive in this community with positive outcomes. Do you work with a patient collaborative? I'm interested in supervising such a project. What kind of project? Athena, I'm trying to look up here to see if I missed something. So I'm not quite sure what kind of project you're talking about, Athena. Listen, peptides in my book are a fly-by-night operation, meaning that I've already done and written about this, for instance, for BPC 157, identified one company that was making this basically in a back alley standpoint in Florida, meaning a strip mall in Florida. The other thing I think you need to be aware of is the FDA has come down hard on this in the last year. So I think you're going to see many of these companies get taken out by the FDA here because they've all now moved to claiming that they're selling these for research use only, but they know they're not selling them to researchers. So I suspect we'll see warning letters, we'll see FDA federal injunctions going out to shut down the companies that are selling these things. Joanna, I had a rollover car accident 19 years ago, an AAI on the right side, according to DMX. How do we know if we have rotatory dislocation or fixation, or just a sublux C1, C2? I'm told dislocation or stuck requires a neurosurgeon, a rotational CT scan. If so, would we know if we needed CT and or needed to see a neurosurgeon? Can you tell from DMX if I might? I'm not sure if my C1 moves with AO care. An updated DMX would be better in my experience than a rotational CT. There are lots of things we can see on DMX where we would refer directly to a neurosurgeon, but that would be the first thing to do. Amin, is it true that CCI OEs causes tethered spinal cord OTC? No, not at all. In fact, I think that this whole thing of occult tethered spinal cord or occult tethered cord, OTC, is for the most part not a thing. You've probably seen my discussions on this. I've had videos on this. We've had Facebook Lives on this. So the answer is no. I think the vast majority of patients that are getting OTC diagnoses don't have a occult tethered cord. They've got a concomitant coexisting back problem that's easily treatable without cutting their spinal cord. Tasha, Chiari0 and CCI have some terrible symptoms now since having my baby 6 months ago. I was wondering if strengthening ligaments for CCI would resolve the Chiari issue as well. Again, Tasha, there is no Chiari issue. Chiari is common in people without symptoms. So that means that Chiari0 is meaningless. Again, I want to make sure you hear that one. Chiari0 has no clinical meaning. I'm going to say it a third time. Chiari-0 has no clinical significance or meaning. Now, if there's Chiari-0 with something like instability, that may make that person more susceptible to symptoms. And that's still being studied, but that would make sense to me. But important to note that Chiari-0 by itself is meaningless, meaning there's many more people walking around out there with Chiari-0s who have 0 symptoms and never will. Brian, could HGH ligament injections be helpful to grow them back? Unlikely, based on the research that we've done. Zigzag, do braces and Invisalign complicate a PICL? I want to get Invisalign, I'm not sure if I should wait to get them. I would say that the TMJ is linked to what's happening in the upper cervical spine. And so you may want to hold off on making any changes there until someone evaluates the CCI component. Rich, can you share who those 2 conservative surgeons are? Yeah, Rich, I don't want to do that in a public forum. Better do that when I'm talking to a patient one-on-one. Karen, in a fall many years ago, left-hand side of base of skull, rattled off corner of a sideboard, and that was out cold. Skull was fizzing and tingling afterwards. Lots of problems since. What happened? I don't know. Yeah, Karen, not a place to get an online consult or diagnosis. Certainly, if you think you might have craniocervical instability, we can do a telemedicine together. I can go through your imaging, your history, and get some sense of whether or not it sounds like you might have symptomatic CCI, but not a place to get an online diagnosis. Athena, thank you for all these exceptional sessions. Happy to help. Corey, how does CCI affect eye movements? Chiropractic neuro found that I'm experiencing square wave jerks as well as vertebral artery compression. Was given bead and string exercises to address eyes. Well, CCI can affect the upper cervical spine. The upper cervical spine proprioceptively is directly linked into eye movement, and that's how those 2 things are impacted. Vertebral artery compression can only be diagnosed using something like a vertebral angiogram with a CT scan. It's not something that can really be diagnosed readily by a chiropractor in the office. So we don't probably know if you have that, but certainly doing eye exercises may be helpful. Sure, AT. HRS, can arthroplasty knee be helped with stem cells? Usually not. Lisa, what are flying recommendations? Not sure what you mean, but I think what you mean, Lisa, is do a lot of our patients fly, or are there any special recommendations for patients that fly? Not really, no. I mean, obviously some of our patients are more physically disabled, and they might need, for example, on an international flight, lie flat seating. Or we certainly see patients who like to put some time to accommodate themselves here in Colorado before the visit, and then some time after the visit before going back. So those are the 2 biggest things that we see with flying. Love. So the sensations of having a bobblehead, walking in someone else's legs and feeling like being in a boat, bobbling on water for over a year, 18 months post-accident can be indicative of CCI. Could be. Those could be indicative of CCI. Obviously, there are many other causes outside of that as well. Rich, do you think taking BPC 157 orally would adversely impact PRP or PICL procedures? No, but I have to tell you, do I honestly think you're actually taking BPC 157 orally and it's having much effect? Probably not. I think that's a whole bootleg world out there that is in the process of being shut down by the FDA as we speak. Okay, guys, we are at an hour and 4 minutes. Let's see here. Corey, interesting Kyra discussed vertebral artery compression with the red saturation test, lifted red cloth and covered eye, and color went black, had biggest problem as well, suspect CCI. Corey, that is not a way to diagnose vertebral artery compression at all. So I wouldn't put much credence in that. If you think you've got vertebral artery compression, I would encourage you to see an MD physician. I would encourage you to get a full evaluation of your vertebral artery. That can include things like an MR angiogram, a CT angiogram, etc. Okay, guys, so thanks for all the great questions. Again, this is a safe space where it's okay to ask whatever question we want and get answers, because in my experience, questions and answers make for better patients. They're more educated, they understand what's happening out there, etc. So I should be back next weekend, I think probably at the same time, 11 a.m., with another discussion and more Q&A. So thanks so much for watching today. Thanks so much for contributing to asking all these great questions. And thank you for being part of this community of questions and answers and helping us all learn. Thank you.